Good afternoon. My name is Camille Niederhauser. I'm a trainee in neurosurgery in Lausanne, Switzerland. And today I have the pleasure to present you a study on the validation and effect of a modular endoscopic training model for biportal endoscopy. Endoscopic spine surgery has become very popular in the last few years and promises a variety of benefits. But training endoscopy requires to overcome technical challenges such as limited depth perception, unfamiliar orientation, and limited surgical field. Because of these reasons, the learning curve is steep, and it was shown that about 40 endoscopic laminectomies are necessary before reaching a steady state. In order to potentially shorten the learning curve, the use of training model has been shown to be effective in other fields. While a training model aims to train specific skills required for endoscopy, namely depth perception, triangulation, and coordination, such a model has not been validated and its effect not demonstrated in spinal endoscopy. To prove that a model focuses on these different skills, it has to show the difference between experts and juniors. In other words, it has to be validated, and this is what we aimed in this pilot study. We worked with the present model as illustrated on the right. It consists of a box divided in 4 compartments. Each of them contains one exercise with its own biportal axis. The objective is to train depth perception, orientation, endoscope positioning, and instrument manipulation. For this validation study, we included 2 experts neurosurgeons practicing endoscopy and 5 novices trainees in neurosurgery and orthopedics with no previous experience in endoscopy. They completed each exercise 3 times in a row and ranked each exercise according to its level of difficulty on a scale from 1 to 10. Experts were significantly faster than juniors in exercises 2, 3, and 4, and more precise in exercises 3 and 4. Exercises 1 and 2 were too easy to differentiate between the 2 groups. We then further investigated whether training with the endobox shows a progression in the learning curve while performing a simulated endoscopic procedure. To that end, we worked with the endobox as a training model and a previously published non-anatomical training model reproducing the steps of an endoscopic discectomy. We included 16 students divided into groups of 8. Group A was trained on the endobox twice a week for 2 weeks. Group B didn't receive any training. From week 3, both groups started with discectomies on the non-anatomical model, twice a week for 3 weeks. All procedures were filmed for blinded assessment by 2 raters. Time to completion was measured. Technique was graded using a modified version of the asset score, which is used for arthroscopy assessment. Finally, mental demand was graded using the NASA task load index on a 21-point scale. As we can see on the graph, the group with the endobox training works significantly faster than the other group, and this effect is consistent from the first observation to the last. With regard to the asset score, the group with the endobox training had a significantly better assessment score than the group, as a reflection of overall improved safety, camera dexterity, depth perception, and quality of procedure. On the other hand, we didn't see any difference between the 2 groups on the mental demand as graded with the NASA score. We can conclude that endobox training leads to faster completion and overall improved dexterity and quality of execution of the exercises. This effect was sustained over the whole period of assessment of 3 weeks, despite the training effect in the non-trained group. Using a validated training model can potentially shorten the learning curve in surgical training if used early in training. Finally, predictive validity needs to be shown in future studies. Thank you.
Okay. Thank you for this very interesting topic concerning progression curve and learning curve. Personally, I tried the endobox last year in the...
Oh, really?
Yes, in the Edu Week, in the endoscopic day. It's quite tricky. It seems funny at the beginning.
Tricky,
it's really
yeah.
tricky. So what is for you the ideal learning curve for I don't know, for a specific procedure like discoloniation with biportal endoscopy, what would you recommend for a resident or for a beginner like me?
Oh, it's a tricky question, actually.
And after how many cases are you considered
Oh,
to be?
how many cases?
Yeah. Because there is a huge amount of papers in the
Yeah.
literature.
I can't really understand to this question. It's too early.
I got to you.
Yeah.